hello to all the participants and my fellow faculty members here on the course. I'd like to start by thanking the course coordinators for putting this together. I know it was a lot of work, and it's really a pleasure to be invited, and I appreciate the opportunity. So thank you, truly. I'm going to talk today about acute shortening. I'm one of the trauma surgeons here at Beth Israel in Boston. I've given a number of international talks before, and it's no surprise to me that most of the people I'm talking to have more experience with some of these trauma issues than I do. Certainly, under more difficult circumstances than I usually face these cases. So hopefully, this is more of a review talk than anything, but these are just some of the cases that I've had to take care of, and one strategy for approaching them. So our objectives for my talk today, number one, to discuss chronic and acute cases where acute shortening to address bone loss is one option for taking care of them. I'm going to highlight some of the uses of external fixator in these cases, both for short-term and long-term care. And then we're going to review the risks and benefits of shortening versus some other alternative strategies that you might have for addressing significant bone loss in these difficult cases. This is the first case that I'm going to talk about. This was a 67-year-old gentleman who presented from Haiti. He was initially treated in this external fixator, and it took him about 3 weeks to reach Boston. As is often the case in car accidents, particularly when they've had some delay to their care, the patient had quite a sizable soft tissue defect. So when we first heard about the patient, our initial thought was that he was going to require free flap coverage, again, for this large soft tissue defect. Now, he was treated initially at an outside hospital, and they took off the external fixator at 3 weeks, and they treated him with a antibiotic cement nail and a small plate. Now, this is a common technique in the United States. This is a rod from the Elizaroff set. This is polymethyl methacrylate cement, which has tobramycin and vancomycin loaded into it. And, the surgeon felt that this would be a good way to take care of a tibia that was, 3 weeks old. The problem is that really the soft tissue defect persisted, and all of this metal that he put in became infected. So at 4 weeks, the case was transferred to our hospital. Now the patient has, got this hardware in place, and everything is infected. So, with open tibias, really, this is things I'm sure I don't have to tell you, but coverage really is the most critical, important factor for these cases. Oftentimes when I'm facing these tibia fractures, I'm much less worried about how to take care of the bone and much more worried about how am I going to get them covered. So of course, acute coverage is ideal, and we, sort of one of the tenet of orthopedic surgery is that we don't leave dead bone behind. But as I'm sure you see in your country, and we see here from time to time, sometimes acute coverage just didn't happen for one reason or another, and now you've got to deal with, an infected area with lots of dead bone. So the number one trick on those is to not leave the dead bone behind. It's just a source of more infection. So I took this patient to the operating room and started to resect the bone that was clearly dead and infected. And by the time we got done, we had, pretty sizable defect. Now the patient had been sent to me already with a centimeter defect. This is probably another 5 or 6 centimeters. And, by the time we get done, we probably have a 6 centimeter or so defect. Now, when you're faced with a defect of this size, what to do is always a challenge. And, the options are really fairly straightforward. You can put the tibia right to the length that it belongs and bring the tibia back out to length, and then plan for some kind of bone graft. If you have the resources and the experience, certainly bone transport is not terribly complicated for a 6 centimeter defect. As the defects get bigger, bone transport gets more difficult. But again, this is resource and time intensive. And I would posit that there's a third option here, which is acute shortening. And that's what we're going to talk a little bit about today. Acute shortening can be quite helpful, and there can be some benefits to it. I would say that there are some limits. My general limit on how much I can acutely shorten somebody is about 2 inches. If it gets to be more than 2 inches, then the sort of technical challenges of shortening them become much more difficult, and I will oftentimes, try and search for some other solution. Um, One of the benefits really of soft tissue coverage with shortening is that it can really make your soft tissues a lot easier. On the other hand, if you don't have a big defect, sometimes shortening people can make your soft tissue coverage worse. So be a little bit careful with your soft tissue and looking at your defects and trying to determine ahead of time whether acute shortening is going to help you or hurt you. I would say for those of you who haven't done any acute shortening, be aware that as soon as you shorten the bone and you let it go, it will go back to its original length. So if you shorten bone, you have to hold it in place at least temporarily for 8 or 10 weeks, or it will spring back to where it wants to go. In general, I find that dealing with a leg length discrepancy is easier than dealing with an infected non-union with a bone deficit. So for me, shortening has become sort of one of my go-to treatments because it allows me to focus on the problem at hand, which is getting the tibia to heal. The leg lengths I can deal with in the future. So in this situation, already infected, fairly sizable defect, but less than 2 inches, I can step cut the bone right here, right? And I can sort of look at this bone and look at this bone and look at the rotation and figure out how I'm going to make a step cut here in order to match this step cut. Now, this step cut came with the patient. This was from his fracture. So all I really did was take a little saw and just trim this back so that it would match. And that allows me to clamp the fracture back in place. Now, again, as soon as I let go with the clamps, it's going to spring back to the length that it started from. So I have to hold this in place. And in this case, I'm going to hold it in place with some lag screws. Now, again, looking back at our last picture, you can see that the fibula is going to be a significant deterrent to me being able to shorten this leg. So I'm going to have to remove a segment of this fibula as well. So you can see here I've removed that intervening segment of the fibula. So fibula taken at the fracture site and removed, and that allows me to acutely bring the tibia down and shorten it. And then we put some lag screws across it. And these lag screws really are just holding the tibia, at length. We add a butterfly fragment in the back here, and I lag that in as well. But it's really these two lag screws which are holding the bone. Now, lag screws alone are insufficient for stabilizing a tibia. And if you just put the lag screws in and then put the patient in a cast or something like that, of course, the lag screws will come loose. So in this case, you really need an external fixator on top of this. Now, it doesn't have to be a complicated external fixator. Here I've used a circular frame, and these are not terribly complicated. They're just held together with half pins. So this is a 5mm half pin. Here's a 5mm half pin and a third 5mm half pin. Here at the distal segment, I just have two 5mm half pins. So these circular frames are not terribly complicated, but they're quite stiff because they do, go all the way around the leg. The frames, even for us here in the United States, are expensive. I tend to, for a simple frame like this, just use straight threaded rods to save on cost. Now here's my lag screws across the fracture. And as I've acutely shortened this 6 centimeters, it's moved from a defect where I'm going to need a free flap to a defect that I can now use rotational plasty. So in the end, my plastic surgeon is going to use, this is perforator vessels off the tibialis posterior, that's going to rotate into the defect. So we're going to take a free flap and rotate it, a local rotational flap and rotate it into the deficit. So we take that off perforators from the tibialis posterior and then rotate that into the deficit, and that closes up my hole. So now instead of needing a free flap, we've been able to treat this patient with a rotational flap. This went on to heal in about 4 months uneventfully. My initial intention was to leave him in the frame for 8 or 10 weeks and then take the frame off and nail the tibia, take out the lag screws and nail it. But the bone appeared to be healing so nicely with just the lag screws alone in the frame that I wound up leaving him definitively in the frame. But of course, the downside to this treatment is that you're left with a significant leg length discrepancy. In this case, the gentleman has about a 2-inch leg length discrepancy, Now, he has steadfastly refused to let me lengthen this at the other end of the bone for the last 2 years. And every time he comes to see me, I'm hoping that he'll give me an opportunity to lengthen this. We'll put the frame back on the top and then do an osteotomy in the proximal third of the tibia and lengthen him. But he's been doing fine with a shoe lift. He's 67 and he's not the most active guy, so he's declined any further surgery. Now, that's a nice case of doing this with an acute infected tibia. Of course, it requires, good soft tissue coverage and good antibiotic coverage. But you can use this technique also in acute tibia fractures, and we're going to review just one more case of acute tibia fractures. If you happen to get these early on, again, our focus on these is not so much what to do with the bone, it's how to stop them from getting infected. So this 24-year-old gentleman comes in with this rather severe accident. He was on the highway and lost control of his motorcycle and was run over by a car, at high speed. So he's lucky that he lived. Accident really isolated to the leg itself. But, we know just from looking at this in our trauma bay in the emergency room that he is going to need a free flap on this. All of this tissue over here is going to die. All this purple macerated tissue, all of this is going to die. Now that's going to allow us to, probably close this a little bit better. But, we've got bone loss here and significant soft tissue defect. So my number one concern for this patient is not what to do with the bone, it's what to do with the soft tissue. Fortunately, I have a good plastic surgery team. So the night the patient comes in to the hospital, I put him in a simple external fixator, and we put a vac on this, and I called my plastic surgeon, and 48 hours later, I took him to the operating room, and I closed down this gap, this bone that was lost. Some of this bone still needed to be debrided back. So I resected the bone at about this level here and at about this level here. Now you can see I have some large butterfly fragments, and I held those in place with some lag screws, supplemental lag screws for the fragments, and then acute shortening. Now again, if you bring the bone together and shorten it with a clamp, as soon as you take the clamp off, the bone is going to spring back to its original length. In this case, I'm using this small plate just to hold the bone in place. This is purely designed to stop the bone from springing apart. Now, once I have the bone covered over with a free flap, in this case, we used a anterior lateral thigh flap, an ALT flap. I can bring the patient back at about 10 weeks. Now, he's again in the similar frame that where our last patient was in, just a simple one ring at the bottom, one ring at the top, and some struts. And I just let him sit there and not get infected. We were able to avoid infection in the first 10 weeks. And at 10 weeks after the injury, I can bring him back to the operating room and carefully, relatively percutaneously remove all of the hardware. So we have a nice clean tibia now, and you'll see that he won't spring back out to length. I took the hardware out, I let the wound settle down, and then 2 or 3 weeks later, I took the frame off. We put him in a cast for 2 weeks to give him a pin tracked holiday, and then I converted him to a nail. So here's his nail. Now this is about 14 weeks after his injury, and here he is 6 months after his injury, everything healed up quite nicely. Now this worked well for us, largely because the patient didn't get infected. We were able to shorten him about 2 centimeters through here to get rid of the majority of the defect. And you can see, we had nice bone apposition here, and that gets rid of the majority of the defect for me. Now, here he is with his 3-foot standing plane films, and you'll see that he is about 2 centimeters, 2.5 centimeters short. And he and I have been discussing doing a lengthening at the proximal tibia to deal with this. But now we can do our lengthening through soft tissues, which are dramatically better than the injury and the zone of injury down here. When you have a very large zone of injury, that's the last place that you want to have to be dealing with the bone loss. So I will acutely shorten these, get away from the bone, get away from that zone of injury, and then do my lengthening proximally where the bone is far healthier. So in conclusion, acute shortening is a pretty simple way to deal with a defect conceptually. There are some technical challenges to it. In particular, the soft tissue coverage can be really difficult if you're trying to acutely shorten people more than 2 inches or so. I think 6 centimeters, maybe 2 inches is reasonable. More than that, I think even if you get it to work, it's difficult to live with. So having a leg that's more than 2 centimeters short is really a challenge. In the arms, 6 centimeters again, I just leave them. I'm happy to shorten, the humerus, um, about 6 centimeters, and patients can tolerate that quite well. Again, this will help with your soft tissue coverage in certain circumstances, but it's not a substitute for a free flap. As in my open tibia case, if you need a free flap, you need a free flap. And then, I would make the point that don't forget to anchor the bone. If you have shortened somebody acutely, it's not going to stay that way. You can anchor them with a nail, you can anchor them with a plate, or use an external fixator. But by holding that bone together, the soft tissues will reaccommodate it. Usually by around 8 or 10 weeks, you can take out whatever temporary device you've got using the holding the bone back together, and then switch. In most instances, I'll switch to a definitive nail. Okay, thank you very much. I appreciate your time, and again, my thanks to the organizers for allowing me to be present today. Thank you so much.